I will give some brief information. It will be such a little bit repeat of former talks, but I will briefly and summarize the main points. And the first of all, we will talk about failure after arthroscopic repair, risk factors, and then failure after bone block procedures. Failure after arthroscopic repair is a very disappointing result, but quite frequent. In some series, it's been reported until 30%. But prevention is possible if we know the reason. The reasons can be grouped in two groups. First, patient-related factors, and second, surgeon-related factors. In first group, we have to be aware of the age, hyperlaxity, and type of sports may influence the failure. And the second group, we have to be very careful, especially I have highlighted bone loss, which will mainly has the main role. ISIS, as mentioned before, is very common in orthopedic community. They have Gawhale et al. They have summarized all these factors: age, sports participation, hyperlaxity, and bone loss in the direct X-ray. If there is more than 4 points, they have advised Latarjet after 3 years of the first presentation. The first times they have only made Latarjet after 6 points. But we know that the age is a big problem, a big risk factor. Especially younger than 20 years, it is 12 times. And also in younger than 30 years, it is nearly 7 times riskier than the older ones. These guys don't know the danger, and they think they are already ready for basketball even after 1 week after the surgery. Also, we have seen in our patients in the earlier periods nearly 6% of radiodislocation and 10% of subluxation, and all the recurrence patients were younger than 21 years. Another problem is, another risk factor is hyperlaxity. And generally, hyperlaxity is a contraindication for surgery, especially in Ehlers-Danlos and Marfan patients. When you see such a dislocation in the X-ray, then you have to stop doing surgery. These are not good candidates for surgery. But there is also a concept of hyperlaxity in shoulder, according to Gawhale. If the anterior external rotation is more than 85%, then there is anterior hyperlaxity. And if there is more than 20% difference between hyperabduction between two sides, then that side is hyperlax. And so other problem is also the contact and collision sports. Mainly the younger patients, they play football, wrestling, other contact sports like rugby in other countries, and arthroscopic surgery is rates of failure. And if they go back to the sports, it's more or less higher rates. And in some countries, surgeons directly give bone block procedure to these patients. When we talk about bone loss, these are important. Then we talk about glenoid bone loss, humeral bone loss, bipolar bone loss, or glenoid tract concept. For example, glenoid bone loss can be in fragment type, and this is related with low risk of recurrence, which is called bony Bankart. But if it is erosion type, then it is high risk for recurrence. So we always evaluate our patients with CT scan, with an unfast 3D CT scan. And so then we use the best fit circle, and the difference between the defect and the largest diameter gives us the percentage of defect. This is very important. And what is the threshold for recurrence risk? Traditionally, it's been known as 25% in the earlier 2000s. Later, biomechanical studies showed us that it is less than 20%, But in clinical studies later, in 2010, 2017 and 20, it is nearly 15 to 13%. If there is a larger defect than 15%, there is a threshold, there is a risk of recurrence. And on the other part, also there is a problem in the humeral side, and it is also related with, it is also called heel sacs, and it is also related with recurrent instability with higher percentages. But the location and length is important, especially length. If the heel sacs length is called with distance between rotator cuff insertion and the most medial part of the heel sacs. And another concept is intact anterior articular angle, which has been described later. And when the heel sacs, largest part of the heel sacs, and there is an intact articular angle, if it is larger than 125, then if it is less than 125, then it's engaging heel sacs in the study. And we can, this angle can be also used for recurrence rate. But the bipolar bone loss is the main problem, where 75% have glenohumeral instability has this bipolar bone loss. And most of them have more than 5, when they have more episodes, like more than 5, there is 82% of bipolar bone loss. And in 2007, the glenoid tract concept of Itoi has come into the orthopedic literature, and it is a bit confusing in the first time, but I tried to summarize in one slide. He has made, after very comprehensive calculations, that 83% of the whole glenoid diameter is in contact with the humeral bone. And we know the heel sacs length from rotator cuff insertion to the most medial side of the heel sacs. And if the heel sacs length is less than glenoid diameter, then it's an on-track lesion. And if the heel sacs lesion is larger than the glenoid, then it is an off-track lesion. So off-track lesions, is it equal to risk for recurrence? Nearly, yes. When it's off track, then the rate of recurrence goes more than 30%, and the odds ratio is more than 8 off track versus on track, and the positive predictive value is more than 75%. Is it flawless? Is this concept? There are some problems, like defect size of humerus and glenoid is used. Capsulabral structures are not considered, or the heel sacs lesions depth is not evaluated. When we compare from the first slides, ISIS, newer studies from all around the world, from Korea, from both sides of the United States, they have criticizing the ISIS because the main problem is they have only looked in the X-rays. So another concept, which is called glenoid tract instability severity score, and there is the first 4 parts is the same as the ISIS: age, type of sport, level, shoulder type, laxity. Only the bone loss is here on track or off track, and the off track lesion gives 4 points. And if it is more than 4 points, then they have made their patients Latarjet. And after the evaluation of the same patient group, they have made less Latarjet with similar recurrence rate like ISAs. So these might be a better evaluation for the patients. And the risk factors have evaluated by the and from the entire world, the experts from the entire world, and it has been published last year. And they have agreed that age, hyperlaxity, collision sports, bone loss, and number of instability events are the most important. And they have also, in another paper of this series, with the same authors, as you can see, they have concluded that Bankart repair is only can be done less than 15, and some of them have agreed that it is 20% of bone loss. But is Latarjet procedure without problem? Is there any risk of Latarjet? A large series of more than 300 patients, the Giacomo and Provencher, they have found that there is 4.7% of recurrence, and their risk factors were atraumatic history, bilateral instability, and female gender. And in our series, we have added another risk factor, which is epileptic patients. In the non-epileptic group, we had 1.8% of recurrence, but in the epileptic group, it has risen up to 23%. And all the dislocations happened before the bone, the graft has healed. So 3 months also operatively. So epilepsy control is very important in the instability surgery patients. What can we summarize? We have to be aware of patients-related factors like age, hyperlaxity, and sport. That it is important when we talk about and consult with our patients, and especially about their postoperative period. Bone loss evaluation is mandatory for prediction of recurrence. Scoring systems and algorithms are evolving. We have to keep reading the new literature, and tailored treatment is more favorable. And Latarjet also may fail, especially we have to be aware of a traumatic instability and epileptic patients. Thank you very much.